Good afternoon, everyone. Can I have your attention? Please welcome Nantucket Cottage Hospital President and CEO, Dr. Margot Hartman.
Thank you. Thanks to everyone for being here with us this afternoon. This is our second year of Women in Wellness events, and you can just feel the momentum in this room. I'm so happy to see such a response from our community to come together on these important topics. I'm just as anxious as you are to hear from our featured speakers, but first I need to thank a few people who have been instrumental in creating this event for us all. I first want to recognize our event chairs, Janine Borthwick, Sarah Boyce, Meryl Braylauer, Chrissy Campbell, Kara Marquis, and Melanie Sablehouse, as well as the entire host committee, which included nearly 40 year-round and seasonal residents. Thank you. I also want to thank my colleagues from Mass General for sharing their wisdom with us today, Doctors Caroline Mitchell, Sandy Tsao, and Mark Wine. Thank you. In addition, our Diamond, Ruby, and Pearl sponsors for all their support, helping us continue to raise the profile for this event and making it accessible to all. In fact, the momentum continues off-season and will continue this next off-season with various events, and these are sponsored on the island by Petticoat Row, which, as many of you know, is an organization, a local organization of women in business. So that's a wonderful dovetail. And last but not least, I'd like to recognize the Copley Group for assisting us with housing for one of our featured speakers and providing them with excellent accommodations during their stay. I'm also delighted to see so many of my Nantucket Cottage Hospital colleagues here. Thank you for being with us. And I'm now going to turn it over to one of our chairs, Meryl Braylauer.
Welcome, and thank you for coming. What a crowd. We're so excited to have you here. We're so excited that this is year number 2, and we want to thank each and every one of you for coming. And I want to give a special shout out for those of you who noticed that Pay It Forward button on the website and paid it forward so that we were able to accommodate a lot of people who might not have otherwise been able to come. So again, thank you. Many of you know this, but I'm going to repeat from last year. Women in Wellness has several goals. We want to present you with the most up-to-date, expert information as possible, and we also aim to strengthen the connections between our local physicians so that when you need referrals from this island to Boston, they know the docs personally. This morning we had a meeting with the doctors from the hospital and the Mass General doctors, and it was terrific for them to meet each other and have a sense of who each other were. How many of you were here last year? Okay, a lot of people, a lot of return. How many of you first time? I'd say that looks like about half and half. That's great. Last year, we nicknamed our event Heart, Sex, and Relax. This year, we're calling it Skin, Bones, and the Microbiome. We're pleased to have 3 outstanding physicians as presenters, Dr. Sandy Tsao, Dr. Mark Wine, and Dr. Caroline Mitchell. Their full bios are in the program, and you can read all the details about how they're all superstars in your information packet. After our event last year, we surveyed you, and the number 1 request you had was skin. So that's why we invited you, Sandy. Dr. Sandy Tsao is considered one of the must-see laser and cosmetic dermatologists in Boston and across the nation. You can see what makes her an expert in her bio, but you might like to know that she has a Nantucket connection. Before medical school, she was here for about 7 years, and you're not going to believe what she did. She collected ticks, okay? She was helping do tick research for Harvard School of Public Health. She was here once a month for 6 to 7 years. This time, she brought her two teenage boys and her husband, Henson. Henson Tsao is somebody whose name you might have heard before because he's and a melanoma specialist at MGH. Hope all of you and your family had a good time. Okay. Can you all hear? No. Oh, I'm sorry. Okay. All right. Thank you. Okay. Can you hear me now? All right. I'm awfully sorry about that. Okay. I'm going to stay right here. Okay. Dr. Mark Wine is a foremost endocrinologist and researcher who will give you the lowdown on your bones, including osteocytes and bone formation. He'll explain in terms that you'll understand, and he'll talk about something near and dear to my heart, and that is fitness in bones. Most of you know that I have a very high bar for doctors that I choose for myself. And he can't tell you because of HIPAA, but I can. He's my doctor. Okay. I just recently transferred to him. It was a very good decision because not only is he smart and thorough, but he's kind, and you know he really cares. He's here with his lovely wife, Sarah, who's also a doc at MGH. She's a rheumatologist. Their 2 little daughters are at home, but we hope you'll bring them next time. How many of you have heard of the microbiome? Okay, not that many. How many of you actually know what it means? Oh my goodness, I'm impressed. We've got an educated crowd. After tonight, you'll all walk out expert. Just kidding. But you will know a little more than you know now. You can read Dr. Mitchell's bio and see that it takes a long while to become an expert on the biome. And that's what her microbiome, and that's what her research is about. She's at the Vincent Center for Reproductive Biology at MGH, and she'll tell you more about the research she's doing. She's got a 5-year-old at home, a little boy, and her sister-in-law who's here with her. They're both working moms, and they got a well-deserved break to coming to Nantucket. What's interesting to me is that she's taught high school in Southern Africa, but this is her first trip to the Cape and the islands. Hope you'll come back, Caroline, and bring your whole family. We're very thrilled, as you can tell, to have you all here, and we thank you for coming to Nantucket and being presenters for this event. Each of the docs will speak for about 20 minutes, and then we'll have a 5-minute Q&A following each speaker. There'll also be a very quick 10-minute break after Dr. Wine, so you can grab some refreshments. Janine, my co-chair, will moderate the discussion. Okay, be careful of this wire. Oh, be careful of this. Oh, sure. Oh, good. Yes, thank you.
Thank you. Well, this is incredibly exciting to be here. I talk very loud. I'm sorry. I have 2 boys. I'm always trying to get to follow what I say. And so I really want to thank Meryl, Janine, and the organizational committee to actually set such an incredible event up. I mean, to see so many women here lights up my heart. I love to educate and to expand our knowledge in our healthcare. And with that, I'm going to get started because there's a lot to cover with the skin. So no discussion. So this is a typical day in my clinic. And when I was asked by Meryl to come and speak about the skin as we age, I was thinking about each of these people has a story. Each of these individuals has had different exposures and different events in their life. But nothing was more telling than this patient who came in to see me. Definitely has lived a exciting life, I'm sure. And there's a lot of memories to think about it. But what was more striking is she brought her granddaughter. And she said, "This is what I would like to look like." And I said, well, I said, sure, me too. But the relevance of the picture really is that we start out with a clean slate. And I think that one of the things that will hopefully come out from this talk is really thinking about what we can do starting now. It's never too late to make improvements in our skin in order to try to improve our lives and live with a very healthy skin. So there are 2 ways of thinking about aging. One is chronology. Every year, thankfully, we wake up, celebrate that birthday. Generally, with our normal intrinsic aging, we don't have a lot of damage to our skin. We do lose a little bony, muscular mass as time goes on, but our skin is actually quite elastic and quite clear. What actually influences our aging is photoaging. That's us going out into the beautiful sun. That's a lot of other exposures that we have on a daily basis that give us more of a leathery, tough, pigmented, red, blotchy, brown, pigmented skin. I love to show this picture. This is my nurse. She lets me show her off because she's 50. And this woman looks incredible. And to me, I mean, there's not a single blemish. She scolds my patients when they're not using their sunscreen. And I'm really very impressed about that because she has put on sunscreen. She is a runner. And this is her. She does marathons and she has no sun. So I always say I run and I have color. And that's why I'm shamed by how great she looks. And so you can see just with chronological aging how unaffected we are. There are other factors that we can't or can potentially influence. I think the biggest change when I entered menopause is loss of hormonal influences. My skin became dry. I saw toughening and a lot of changes to my skin that I found very frustrating and fully understood when my patients came in looking for some moisture to their skin. That estrogen plays such a tremendous role in helping to keep our skin healthy. But oftentimes we will not be able to supplement depending on our background. And so it's something that we actually have to adapt to and supply. The other shocking thing to me is actually tobacco use. And I think that's one of the things, gratefully, that we're seeing a reduction of in many instances. But tobacco use, a lot of the changes when we stop smoking are reversible. With the skin, they are not. And so I find that actually quite fascinating. And you do see that with the yellowing and the thickening and the bronzing of the skin. So there are factors that we could definitely eliminate over time that can help us to keep our skin healthier. But what really happens with age is that we call it the epidermis, that top layer, it becomes thinner. That's our barrier to the world. So we become more fragile. We see more easy bruisability. We see wrinkling. We see a bronzing. We see decreased vitamin D absorption. We see less repair of it, so we get the wrinkles. And so what we try to do is minimize that with some challenges. But what we do see, we see the wrinkles, facial folds, dyspigmentation, dullness, sliding in a little slower, and facial blood vessels. This is what people come to me to actually reduce and get rid of. But I'm hopefully going to send a message that there are a few things we can do before you have to come and see me to minimize having to come to see me. But this is a perfect example of someone whom has definitely weathered a little bit of time, has a lot of the changes that we worry about with the discoloration, wrinkles. She's had a skin cancer. She probably has a couple of others. What we can really do with this is actually come and see a doctor regularly and making sure that we get some good advice, because not only do we age on our face, we age on the remainder of our body. And it's very important that, we learn to protect these areas and provide the best care. So what can we do? Well, photoprotection is the mantra for dermatology. And it's something I'm going to spend a lot of time on because I think it's really the message in order to try to protect our skin. We can also use products such as alpha hydroxy acids and retinoic acids. We can probably change. We can always ask our obstetricians, gynecologists for help with hormone therapy. And then there's always the cosmetic interventions. So what causes sun damage? The biggest cause is ultraviolet B. And this is a light that, though it is 90% absorbed by the ozone, the 10% of which causes the most damage to our skin. This is actually what causes the sunburn. And once it's absorbed into the skin, it causes some genetic changes that make us more prone to developing skin cancers. And so we absolutely know that excessive acute UVB assaults to our skin, so multiple sunburns to our skin, increases our risk of developing the skin cancer basal cell carcinoma and melanoma. If you have chronic ultraviolet B exposure, it increases our risk of developing actinic keratoses, which are precancerous lesions, and squamous cell carcinoma. So UVB is the light that causes a lot of our worrisome damage. And this is an example of a patient, I will say, out of a book, but in July, people hate to come to see me because they oftentimes have sunburns or they have their tans, and they're like, I really need to see you another time, Dr. Sa. And I'm like, well, I'm glad you are, because we're going to talk about that sunburn. But again, acute cumulative sunburns actually are something that that we try to educate against. And for our children, grandchildren, a message that we send in Australia, they're incredible, actually. They cannot walk out the door without a sunscreen, and they are not allowed to play on the playground without a hat and sunscreen on. It is actually, they will be kept inside. They will be kept indoors. So they had the highest rate of melanoma in the world. It has markedly been reduced. And we have a lot to learn and educate ourselves about. They all wear hats. They all have the sunscreen. And the schools provide shelters for the kids to play under. And it is the American Academy of Dermatology does have grants that they provide schools with to try to put them out. But a lot of people don't even look for them and accept them. And so, we in America really do have a lot of opportunities to increase the prevention of skin cancer in our children. But for us, just putting on that sunscreen. I have 2 boys. I arm wrestled them for years to get that clothing on, but they have definitely learned to do so, and it's made hopefully a difference in their life. We also have ultraviolet A light, and it does not tend to cause as a significant amount of damage for skin cancer risk, but it is what is absorbed through our windows in the car. It is the most absorbed into our skin, and so this is what causes our actual photo damage changes, our bronzing, our wrinkling, our discoloration to the skin. And it can also play a small role in developing oxygen-free radicals for damage to our skin, and leads to the development of skin cancer along with that UVB light. And this is what UVA creates. This patient who came to see me recently. So where do we get our exposure? We all think, well, lying out on the beach feels great, wonderful. Yes, that is pretty good sun exposure. Tanning beds, very significant light exposure. And in fact, the CDC about 8 years ago came out with a statement that I've never seen the CDC come out with, which is basically there was a causal link between chronic tanning bed use and the development of melanoma. And so that is a very big message for all of us to not let ourselves, our teenage kids, anybody go to the tanning beds, because they have a very powerful legislation to encourage us to go to tanning beds. And it is truly probably one of the worst types of light, because it's very intense and very large doses in a very few minutes of time. But this is who I worry about. I worry about all of you walking to work, walking to the store, doing everything. Many of my patients say, well, I'm just running to run an errand, but this is where we get the most sun exposure, is walking to and fro work, to our businesses, dropping off our children, doing our errands. And so putting on a sunscreen with a good moisturizer every day should be a must, and on your counter next to your toothbrush and toothpaste, because it really is where we are getting most of that sun damage. Our children, don't let them out the door without some kind of sunscreen and hat and sunglasses if they allow it. We have medications that we take. Speak to your doctor. If you were on a sunny vacation, if you live in a sunny area, a lot of your medications may make you prone to getting a sunburn. They're common diuretics, cardiac drugs, many of the acne medications, vitamin A, and it's very important for us to know that, because if you're noticing that you're burning very easily when you're out in the sun, it may be due to a medication that you're taking. So what can we do to prevent this? Well, clothing and hats and sunglasses are probably the greatest thing that we can give ourselves. Right now, there are a number of clothing stores, Coolabah, Solumbra, I'm always happy to provide this information later, that are clothing outlets that are developed by melanoma patients who actually provide UVB protective clothing. And it is wonderful. I love it. Coolabah was actually in Murray Shoggery. So I saw it in there. So it's fantastic. I'm always looking to see what products are available from a skin perspective. And there they were. So using a hat, not a straw hat, if you can hold your hat up and there's light going through, it's going onto your skin. You need to have something that does not have light shown through. It's important to cover the back of your neck. It looks a little silly here, like you're going on a safari, but if you go online, you'll see some others that look a little bit more glamorous, a little bit more accepting. And I think we oftentimes forget sunglasses. And sunglasses of any type are helpful, but you would like to actually have a label that has the UPF factor on it, but at least an SPF 50 or greater, because chronic sun exposure to our eyes increases our risk of getting cataracts. And so it's very important for us to start early and try to prevent that. And this is what could really be my family. Honestly, you should see my husband if he's ever on the beach. You can't even recognize him. He has a hat on. He has a long sleeve. He has long pants. I'm not sometimes sure why he's even going out there, but it's he's out there and enjoying it. But he's a perfect model for it. So you can see the hat, the gear, and this way you don't have to worry about your sunscreen because you have an UPF of 40 or 50 on, and you've already set for the day. And it lasts for a number of washes and very easy to manage. So a really important aspect of your summertime gear. If you don't like to use clothing, there is a product called SunGuard, and it actually is something you put into your wash, and it actually provides a UPF 30 that lasts, I think, for a number of washes, 20 future washes. And so it's usually safe for the clothing and doesn't actually cause any damage to it. So if you may want to do a spot test on some of your clothing, but generally it's a great UV protectant if you really do not want to use some of the other clothing and you just want to use your outfits. This is a Tindazorb, which is a great UV protectant, so SunGuard. So what about sunscreens? Probably the most common question I get in my clinic is, doctor, you told me to use an SPF 30, but is a 15 or 30 any better than a 15? Is a 100 any better than a 30? Well, from a percentage-wise, not so much. But when you're talking about skin cancer, when you're talking about photoprotection, if you know you're going to be in the sun, I would say use the higher number. You're already putting it on. You're already going to get the benefit. So going from a 93% to a 97% blockage of UVAs is tremendous to me. It's 4% difference, but that may be the difference between getting a skin cancer and not getting a skin cancer. So I think it's definitely worth. I put on an SPF 85. I tan the moment I walk outside, and I test out all the sunscreens, and SPF 85, Neutrogena Ultra Sheer. I have no stock or anything in that product, but I'll tell you, does not leave me white or cakey. It actually has the elegance of an SPF 30. They formulated it that way. I've been at the company, and it is a really nice sunscreen. So the higher the number, the better. That's my recommendation for you. The American Academy of Dermatology does just recommend an SPF 30. We do want broad spectrum, and broad spectrum means it's going to cover UVA, UVB, and have a physical block. The physical blocks are your titanium dioxide and zinc oxide. A lot of people are very understandably concerned about the chemical ingredients in sunscreens. And if that really is something that is something you would like to avoid, then definitely look for a product that has at least zinc oxide, because that is the better of the physical blocks. But if it has a combination of zinc oxide and titanium dioxide, it would be terrific. And right now, the companies have heard the mantra. They actually understand that they need to provide these products for us, and they are. So almost every sunscreen company will have a physical block for you. You just need to look at the ingredients. You also want it to be water resistant because you're going to sweat it off. Most sunscreens, basically, when applied to the skin, last about 2 hours. So that's the biggest mistake that we all make. We go on, I'm sure we're very good about putting it on. 2 hours, you're out with the kids, you're chasing them, you're doing things. Oh my gosh, I'm a little sweaty. If you are at that point where you're like, between not applying a sunscreen and putting on a sunscreen, get a spray sunscreen. Those are not our favorites, but they work great if you're going to be out there and you'll put it on. And the way that you do that is you spray it into your palm and you rub it on as a liquid, because then you would be more able to cover the full body surface area of your skin rather than missing it with a mist. So rub it on and place it on. And the other is check the expiration date on your sunscreens. Many of us actually keep it from season to season, and they make it incredibly difficult to find. It's on the seam of the closure of your sunscreen. But I bet all of you will actually go and look at home and say, oh my gosh, that expired a year ago, because I do that. And I think, oh my gosh, I've been putting it on my child for 3 weeks and it's gone. So either just throw it out every season or check the expiration date and make sure that it actually works, because the chemicals do degrade quite significantly. So it's actually very important to do so. And you need to understand that it takes an ounce of sunscreen to cover our skin. So 1 6-ounce bottle of sunscreen should only last 6 applications. That's how much it takes. So it really is a shot glass full of sunscreen, and that's how you're actually properly applying it. And so you really have to think about that and really lather it on. So what about artificial tanners? Well, they're actually quite safe for the skin. I love it because you look tan, but you're not getting the bad UVA and UVB rays, but it's not protected. They are not protected for the sun. Most of them do not have a sunscreen in it. You can definitely apply them onto the skin, but you still need to apply your sunscreen on top of that in order to protect your skin. But they are great, and people are using them so much and so frequently, and I'm really happy about that because they can look quite natural, like a tan, and if that really is something that's important for you, and it really is for many people, then I think this is the way to go. So once we have the sun damage, can we reverse it? So there are definitely a number of medical and surgical strategies that we have to make better. And I think the most important is to see some of the things that we're worried about. So I was saying earlier to a couple of my colleagues, dermatology has the most gruesome things, and I really promise to keep it not so much for you. But I do need to show you a few things that we need to think about. This was a woman in her 70s, and she had some non-healing scaling patches on her skin. Very common. We call them actinic keratoses. These are precancerous spots to the skin. They are an indicator that a person has had significant sun damage in the past. And she had a number of them. And as I had looked across her skin, I could actually see a number of tiny little scaly dots. They're almost better felt than seen. But what I did is I treated it with a topical medication called topical 5-FU, 5-fluorouracil. And you can see not only were the couple of red spots done, but all of this area indicated photo damage to her skin. So not only did I treat actively, but we preventatively treated some that may have come about. And you can see her about 6 weeks later. And pardon me. And this is, I'm going to show you gruesome. And this is actually her skin looking wonderful. So seeing your dermatologist regularly, seeing your primary care doctor regularly, and identifying these lesions and addressing them early will truly prevent help to reduce the risk of developing a skin cancer in the future. So what happens if we do? Well, this are 4 examples of the most common type of skin cancer called the basal cell carcinoma. And you can see they come in a lot of different flavors. This is the most common type. It's a scaly patch that just doesn't heal. And you can say, doctor, I've had this for 3 or 4 months. It just isn't changing. Or it can get heaped up and have a little erosion on it. It can sometimes look dark black, though I would worry about melanoma skin cancer for this one rather than basal cell carcinoma. And very rarely can it appear as a scar that is growing. So that's an unusual finding. But I've had a few patients. This is called the morpheoform basal cell. And so these are definitely the most common type of skin cancers. Thankfully, the most easy to cure, because they don't like to metastasize. And so even though they are common, generally we have many medical and surgical options to manage them, and we take care of them easy. And the recurrence rate is 98, prevention rate is 98, the cure rate is 98 to 99%. So truly nice to identify. If you ever have to have one, this is the flavor to have. There were other types of skin cancers. This was, again, another scaly patch. Doctor, only single one, not healing, been there for a year, came back for their physical. And this actually is a closer look of it. And you can see some scale. It's red. It's inflamed. Or another patient who said, gosh, I have it looks like a mole, but it's growing a little bit on my skin. A little closer up, we have some telangiectasias and some clearing, translucent look to it. This is a squamous cell carcinoma. So squamous cell carcinoma is the second most prevalent type of skin cancer. Again, very curable, identified early, but can metastasize. So it is a cancer we do like to remove when we see it early and make sure we do it, because it can grow rapidly compared to basal cells, which tend to be very slow growing. So you can see that there's a number of risk factors. The number one risk factor is sun. And so we definitely need to be careful about these instances. This is someone near to my heart, my husband's patient, who generously shared this picture. And the reason being is because we oftentimes have people come in, we have these benign growths on our body. We may have a number of moles on our body. This was a patient who was seen 2 months earlier by someone, and actually had a new growth. And all of them kind of look the same, don't they? But what it takes is thankfully a trained eye to see that this one actually is a melanoma. And so when you have a lot of growths on your body, go to your doctor, have them look at them, and if they all look great, have your significant other, someone you trust, look at your skin, because we can't look at our back. And so I usually say, go home and tell your wife, honey, everything is fine. These look good. Or I'll make a mark and say, this. I know your wife is going to look at this and be angry, and so make sure, your husband's going to look at this and worry about it, and this is okay. And I think it's really important, because we do need some assistance in identifying things at times. But if you ever have a worry, again, contact your doctor, and they will definitely help you to either identify the lesion or send you to a dermatologist who can definitely help out. Because melanoma is the skin cancer that we worry the most about. It is continuing to rise in number and incidence. And it's not because we're detecting it more or earlier. layer, it is because it is on the rise. And so despite all efforts that we're doing, it is definitely is still a very prevalent skin cancer. The one good thing about melanoma is that we've become much better at treating it at later stages. And so for me, that has been the sunshine of our field, is in really having very effective medical management options for our patients who have more widespread disease. And so even though this is a very sad slide, we are so much more clever about managing it. So that's really changed the way we manage it. But identifying it and getting evaluated is very key. We actually like this adage of A, B, C, D, E, asymmetry. We keep getting moles our lives. We want you to be able to bisect them in half, have all sides look equal, and if they are, it's generally okay. If the borders are changing, it's becoming irregularly elevated, if the diameter is increasing, or if it's elevated, definitely speak to your physician about it. And if it itches or bleeds on its own, that's another sign for me. So definitely never hesitate. We in dermatology so appreciate you giving us a call saying, I have something I'm worried about. I'd rather reassure you or sample it than let you sit there and worry. So once we've taken care of your skin, made sure that you don't have any skin cancers, there's some really great things that we can all do to our skin to prevent a lot of the changes that we see. And so I get this asked every day, doctor, what should I do? Well, we know that we're going to put on that sunscreen, but you can actually do it with one of your moisturizers. So most of the moisturizers these days come with an SPF 30 in it. So you started out your day, moisturizing your skin because you're losing the estrogen. You're putting on a good sunscreen to block out this photo rays, and you want a mild exfoliator, something like an alpha hydroxy acid or a glycolic acid. So look at the products, Neutrogena, Oil of Olay, what La Roche-Posay. These are products in CVS, Walgreens, Target, all the places that really do not have to be expensive. They just need to have the active ingredients. And if we want a little bit more, a topical over-the-counter or prescriptive retinoic acid, which is a topical vitamin A, works beautifully for our skin to actually prevent a lot of the signs of photoaging. And there was some great research out of the University of Michigan that started about 18 years ago that showed that the vitamin A actually thickens your epidermis. It actually is a collagenase inhibitor, so it helps to minimize collagen breakdown. It thickens your blood vessels. It does so many good things, and it works continuously. So there is not a point at which it becomes prohibitively harmful. It continues to work. So this is something that has been shown to continue to help us. And I'll show you this great picture because I'm the laser cosmetic world, and we always show befores and afters of things that we do. And this patient has a photo, and this is after. And I would tell you in a crowd of my colleagues, what procedure was performed, and they would list off 5 different things. This is topical retinoic acid for 3 months. And so that is what it can do to a patient. So it is really very helpful to use. The only thing we need to be careful of is that it does make us more sensitive to the sun, and it can in the winter be very dry and irritating. So if you're already using it and you live on the island, I wouldn't worry about it unless you know that you're going to definitely spend a lot of time in the sun. Stop at 10 days before that sun exposure, and you can restart it when you get back. But truly a very, very helpful topical agent to prevent a lot of the signs of photoaging. If you don't have that, and I'm just going to look at our time to make sure that we have some time, I was going to share with you some of the wonderful things that you can do. We don't have too much time. But, we can do Botox to soften our lines and wrinkles. This is my other nurse, and she loves it because she no longer looks worried or angry, worried and nice and soft. And we can also soften necklines, which is great. These are all the wonderful, fun things that we can do right now. So this is the cosmetic aspect of this, and letting you know that we have ways to erase a lot of our photoaging. Sometimes when we have a static wrinkle that is deep in line, we can smooth it out. This was a patient that I used one of our devices developed at the Women Laboratories called the fractionated resurfacing device. And what it does is it sends microscopic collimated areas of heat across the skin. And that heat causes a little localized thermal damage to the skin, resulting in new collagen formation. And so it is a way to trick your body into creating new collagen. And this is kind of a funny slide to show you, other than to let you know that this is our normal skin. This is the epidermis, the top layer. And this is something called the stratum corneum. This is what we shed every day. Whoop. Oh, my goodness. And let me go back. Sorry. I am really like button happy here. I apologize. But there we are. But this is very thin. This is very sparse in anything. This is we call a collagen stain. So the stain is positive when it's brown. The two are stained with collagen. You see no collagen formation here. This is 3 months after me doing a laser treatment, and you can see how much collagen activity there is. This is much thicker. It's much healthier. And so we've restored your skin to a probably 10-year previous perspective, and it is long lasting. So it is truly a wonderful laser that can not only take someone in their 30s with only about 3 to 4 days of downtime, someone a little bit older with a little bit more wrinkling, to a nice smoother appearance to the skin. And the benefits definitely last about 5 years. And oftentimes, remember, we age everywhere beyond the face, so we can get rid of some of the reticulated pigment on the neck, and we can also treat the chest. And so, we do have wonderful ways to try to reduce our skin. Well, I'm back to my nurse. She has actually aged a little bit, just from her chronological age. And what she's aged with is some hollowing and some loss of her musculature and volume. And so we do have the ability to augment all of these areas with fillers. And there is no quick fix, so please do not grab this off the shelf. These are caffeine-based, capsaicin-based lasers that will give you the beautiful Kim Kardashian lips, but they will be very painful and only last for about five to 6 hours. But what we can do with the ability of fillers is to soften lines. And I'd like to show this woman who was not able to have a surgical procedure to lift. She said, please help me. I'm really tired of my jowl. And after 2 sessions, this was her. And it looked much softer and much younger. And she was very happy with the results. And we do treat hands because they do age as well. And you can see on the left, no treatment. On the right, a filler into the treated hand. And you can see how nicely we actually can augment. So these are some of the wonderful things you can do. Melasma is a very common problem. And beyond camouflage makeup, do not use bleaching creams. They tend not to work so well. They can cause a lot of damage. But we do chemical peels to improve the skin. But don't do them on your own. Please let a doctor do it. I just pulled this up online on Amazon because a patient had applied a 30% peel and was completely brown on her face. And I'm still working with her a year and a half later to get rid of that pigment. So I'm just about done, other than to say many people here as we age have a condition called rosacea. It can be very debilitating because you get a lot of acne-like bumps and a lot of flushing and redness. And though we do have some medications that work quite nicely in the right setting, either with a cover-up or with a laser treatment, a young girl who was tired of being told she was cute, it was nice to get rid of that, and a little older, getting rid of those capillaries. I am eager to try to do this procedure as we get older and we get more lax skin. You can now get rid of the little jowl with a product called Kybella, which is a deoxycholinase, which is a fat cell killer. And it works beautifully. This is 2 treatments. And we also can freeze fat now. And so this is a patient who had his fat frozen on his neckline to get a sharper jawline. He was still competitive in the market and wanted to look younger. So we are developing incredibly things to make ourselves look great. And I love them. This was a combination of Kybella and laser, and you can just see the differences that we can do to make ourselves look younger. So, closing message, I know we all love to do this. Please try to limit it or use your sunscreen. This was a cute 20-year-old medical student who came to my clinic and said, what can I do? And I just said, keep practicing what you're doing because you look great. Good sunscreen, wonderful moisturizer, and you'll age beautifully. She's also aged beautifully. She came to see me. She was wonderful. She just wanted, I can't even remember, a tiny little brown spot off. And I thought she was coming in for the wrinkles and the lines and the pigment. She was like, I have this little spot, and I loved her. I gave her a hug. I asked her if I could show her a picture because she loved her skin, and so did I. So I do hope that we age all gracefully. Use your sunscreen, and come see us if you have any concerns regarding any worrisome or non-worrisome issues. Thank you so much for your time.
Thank you, Dr. Sau, so much for that amazing presentation. We have time for a couple of questions if people would like to ask. Sure.
Does vitamin A have to be topical, or can you take vitamin A ingest?
What a great question.
wanna use-
What a great question. So the question was, does vitamin A have to be topical, or can you take an oral version of it? And it does need to be topical in order to go into the skin. And that goes for any product that you cannot take oral collagen to make your skin get stronger. You cannot take oral vitamin A to make your skin get that beautiful benefit, because it's not able to get into the body and be absorbed into the skin. And that is one of the things that a lot of companies do try to sell us. So, but it's readily available as retinol over the counter, or as a prescription from your physician in the form of something called retinoic acid or tretinoin.
You talked a lot about taste, which is great. Is there anything that can be done to help prevent or diminish crepiness that goes on?
So that is truly our biggest dilemma right now, is how do we improve crepiness? And the fractionated laser that I showed you does have the benefit of improving crepiness on the face, but it's not as safe to apply on non-facial regions. And so we are in the middle of trying to become better about doing that. We also are not so great about the little wiggle and jiggle that I'm starting to develop, that I used to tease my grandmother about, and now I'm becoming. And so lax skin, stretch marks, and the creping. But maybe in the future talk, we'll have some other ideas to share with you at that point. Mm-hmm. Yes. Yes. Oh. No, you go ahead. Sure.
There seems to be a big interest in oral collagen these days.
Yes.
And it's very well marketed. Is oral collagen or topical collagen, is it factual? Is it helpful?
So there's no studies to date that show that oral collagen is beneficial for the skin. So if you there's no data to date that shows us that oral collagen is effective. So, but what you can do is you can put on an antioxidant like vitamin C with vitamin E and B5 complex, and the topical vitamin A, and those are definitely tried and true, proven benefits for increasing your collagen thickness.
I think we have one back there.
My question is, there's a lot of fear about chemicals in the sunscreen,
Mm-hmm.
and they're one that's been banned by California. And how many of the sunscreen companies are trying to do better on what they put in?
So that's a great question. So we do, as we had mentioned, have a big fear about a lot of the chemicals in the sunscreen. Actually, what just happened is that Hawaii, and starting in 2021, has banned sunscreens that contain two active ingredients, oxybenzoic acid and oxybenzoate, because it's killing the coral. And so I'm sure we're going to be seeing that similar legislation around the world. But the one thing that I would say is that the companies definitely in the past 3 years have provided us with the physical blocks only with the zinc oxide and titanium dioxide in it that are absolutely safe. They are truly just not absorbed, not a chemical, not proven to be harmful. So they have leaped right on board, and they're out there.
We have time for one more. Elizabeth?
So there are 3 brands that I recommend: Neutrogena Ultra Sheer, La Roche-Posay, and Blue Lizard. And each of those has physical blocks that are very effective. And so it kind of gives you marketing. We have just one more question because you were so patient.
If you've had melanoma, which I have,
Yeah.
what's the propensity to get it again? Is there any?
So what a great question. So if you've had melanoma, do you have an increased risk of developing a second melanoma? And I would say the likelihood of developing a second melanoma is very low. But it's very important to monitor your skin, generally every 6 months skin checks for 5 years, and then yearly forever, because there was a paper that my husband actually had authored that 15 years out on melanomas that we thought would not recur. Actually, there was a low percentage of recurrence. So not so much, but there are atypical moles, dysplastic nevi. If you have more than 20 or 25 of those, your risk of developing melanoma is heightened. And if you have a family history of melanoma, your risk of developing melanoma is higher as well. So any family history, a history of atypical moles, definitely worth having your skin examined at least yearly. Okay. Thank you so much. It's been such a pleasure. I appreciate that.
Thanks so much, Dr. Tsao. And now we'll go from skins to bones with Dr. Wine.
Let's see. this one. Well, first of all, I wanted to thank the organizers, and especially Meryl, for this wonderful opportunity to attend this exciting event. We're going to be switching gears a little bit, although I just learned a huge amount of things that we could do for our daughters moving forward, so I appreciate that. My disclosures are listed here. So osteoporosis is a very common and serious problem in our aging population. Osteoporosis is defined by one of two things, either having a low bone density, which we'll discuss in subsequent slides, or the presence of a fragility fracture, irrespective of bone density. So a fragility fracture would be defined as a fracture that's sustained from a fall from standing height. So most people probably would break bones if they were involved in a motor vehicle accident or were to fall off a building. But we're defining fragility fractures as fractures associated with minimal impact. And this is a common thing. We have 9 million of these annually in the United States. And all of these fractures are significant medical events. They lead to significant pain and disability. Of all the osteoporotic fractures, hip fractures are particularly devastating. If you're over 60 and break your hip, unfortunately, there's a 20% chance that you won't be alive in a year. And unfortunately, there also is only a 50% chance that you'll regain full functional independence. So these are major fractures that have important impact on our health. So beyond these kind of staggering epidemiologic numbers, this problem has important clinical, personal significance. So this is a picture from a recent gathering at our house, and I wanted to highlight my grandmother, who also has had a lot of skin damage. She's 89, and in addition to skin damage and multiple squamous cell cancer, she's lost 3 inches of height, and she has sustained multiple fractures of her both hips, spine, wrist, elbows, and knees. Luckily, she remains independent. But having seen kind of what she's gone through personally, this has provided major motivation for me to better understand this problem and to come up with new ways to help people whose skeletal fragility places them at increased risk of these fractures. And one of the most important reasons that I care about this is because a lot of the impact, a lot of the risk associated with osteoporosis is genetic. Her great-granddaughters or my daughters may have to worry about this in the future. So with that kind of background in mind, the components of the talk that I wanted to cover today are listed here. So first, we're going to talk a little bit about bone biology. Bone is a living tissue. Next, we'll talk about changes in bone mass that occur over our lifetimes. And finally, we'll think about what we can do about this. What can we do in terms of lifestyle modifications, and what can we do in terms of treatments to boost bone density and reduce the risk of fracture? And finally, because this is a topic that's near and dear to my heart, I wanted to touch on what the future holds and where this field is moving. So in medical school, we learn that the amount of bone mass we have is really determined by the balance between 2 types of cells in bone. We have these cells called osteoblasts. And what osteoblasts do is they build bone. So these are kind of the good guys, and they're responsible for bone formation. In addition to osteoblasts, we have osteoclasts. And osteoclasts do the opposite. They destroy bone. So it's really the balance between bone formation by osteoblasts and bone destruction or bone resorption by osteoclasts that determines our bone mass and therefore our fracture risk. So because the way I wrote this slide, I learned this in medical school, now we know more. In addition to osteoblasts and osteoclasts, there's a third cell type that is extremely important in bone called osteocytes. These are beautiful cells. They live within bone. And as you zoom in on them in higher power, you can see that these cells, they have these projections that allow them to talk to each other. And they, importantly, in addition to talking to each other, these osteocytes talk to cells on the bone surfaces. They talk to osteoblasts and osteoclasts. And I think of osteocytes as the conductor of the orchestra of bone remodeling. So osteoblasts are always building bone, osteoclasts destroying bone, and the osteocytes are telling them what to do. The way they tell us these cells on bone surfaces what to do is by making locally secreted hormones, whose names are listed here, that can either turn on osteoclasts or turn off osteoblasts. And by kind of conducting the orchestra of bone remodeling, osteocytes are responding to the cues that are occurring outside of bone to determine the rates of bone remodeling. And so really there are two very important sets of cues that osteocytes respond to. And those are hormones, which I'll talk about, as well as mechanical forces. So first, let's focus on hormones. I'm an endocrinologist, so I care tremendously about hormones. We just heard about estrogen as a hormone that is important for both skin and bone. It turns out that the hormone that's the most important in controlling bone homeostasis is something called parathyroid hormone. So parathyroid hormone is made by 4 glands in our neck called parathyroid glands. And these parathyroid glands, their job is to keep our blood calcium levels normal. Our heart, our brain, we really need to have those blood calcium levels just perfect. So what the parathyroid gland is constantly doing is sensing the amount of calcium in the blood. And if it starts to dip, the parathyroid gland secretes this hormone, parathyroid hormone. The hormone then travels into the blood and goes to bone. When parathyroid hormone goes to bone, what it does is to increase bone destruction. So because 99% of the calcium that we have in our body is actually stored within our bone, not in our blood. So this is a great store for calcium. And so what PTH does is it liberates some of that skeletal calcium store in order to bring the blood calcium level back up to normal. In addition, parathyroid hormone has important effects in the kidney and the gut. And once calcium is released through this loop, then that tells the parathyroid gland to stop making parathyroid hormone. So we'll come back to parathyroid hormone in subsequent slides as we talk about what we can do with calcium and vitamin D to help keep our bones strong. The other important thing that osteocytes do is that they respond to mechanical forces. I bet you didn't think you were going to be seeing a picture of an astronaut. A huge problem that NASA faces is that with prolonged space flight, dramatic amounts of bone density are lost. And this is because essentially with space flight, our skeleton is unloaded. You're not getting that mechanical stimulation on our bones, and that leads to rapid bone loss. Conversely, when you look at professional athletes, and tennis players are kind of a great example of this, they have higher bone density in their dominant arm compared to their non-dominant arm. So these are x-rays from a tennis player, and you can see that this right humerus is kind of thicker than the left humerus. And this is a perfect example of the dramatic and potent effects of exercise on bone mass. It turns out that osteocytes, my favorite cell type, are the primary mechanosensors in bone. So they are the ones who are constantly sensing the gravity or the lack thereof, or the exercise or the lack thereof in spaceflight, and interpreting those signals and relaying that to the cells on the bone surfaces. How do osteocytes do this? Now we're zooming way in on a picture of one osteocyte. This is the cell body, and this is the nucleus. And what you can see is that coming out of that cell body, there are these little projections. And now here on the right, we're zooming in on one of those projections. Here's the projection, and in the space between the projection and the bone, there's a tiny bit of fluid. When we exercise, this fluid moves. And basically, osteocytes are always sensing how much fluid is moving over their projections and relating that, and that's how they sense mechanical forces. So we always want to keep in mind that exercise is good for our heart, good for our lungs, also extremely important for our bones because it causes that fluid around the osteocytes to move. So I hope I've convinced you that bone is a living tissue. It's constantly being remodeled by osteoblasts and osteoclasts. And osteocytes are really kind of at the center of all this. They're orchestrating what blasts and clasts are doing in response to cues like hormones and mechanical signals. So now we'll move on to kind of how this fits into our lifetime. In the next couple slides, I'm going to be showing a series of graphs that show the changes in bone mass over our lifetime. And importantly, what you can see here on the y-axis is bone mass and on the x-axis is our age. During puberty, we accrue or accumulate a tremendous amount of bone. As you can see, the maximal rate of bone accrual happens right around the time of puberty, of 12 and a half for girls and 14 for boys. And so such that by the age of 18, we've already accumulated 95% of our bone mass. Peak bone mass is then achieved at around the age of 25. And unfortunately, after we turn 25, there's really only one direction to go. So we want to focus on our ways to kind of slow down that decline. And in thinking about this, kind of after peak bone mass is achieved, there is a gradual decline in bone mass, and such that with decreasing amounts of bone tissue, the fracture risk does increase. And it's really kind of this combination of things that happen as we age. Obviously, menopause is a major transition that women go through, and estrogen is good for bone. So the lack of estrogen in menopause does cause some of the bone loss, but there's more to it than just a lack of estrogen. There are factors intrinsic to aging that we're just now beginning to understand that probably play an important role in this decline with age. And so what can go wrong? Unfortunately, there are a number of things that can go wrong, kind of that lead to an increased fracture risk at an earlier age. So you can imagine that if bone mass is slowed, bone mass accrual is slowed during puberty, that could lead to lower peak bone mass, so that you could kind of get into this green portion of the graph a little bit earlier. And in addition to problems during growth, you can imagine a number of other factors. And these are really the important, as I see patients and evaluate them for osteoporosis, we're kind of thinking deeply about all the potential things that extrinsic risk factors that could be contributing to changes in bone mass. So for example, if early in life there are problems with irregular or abstinent menstrual cycles, early menopause, eating disorders such as anorexia or any other condition that leads to malnutrition, hormonal imbalances like too much parathyroid hormone, too much thyroid hormone, too much cortisol, immobilization, because remember, the astronauts lose all this bone mass. There's a long list of medications and toxins that can affect the skeleton. And in general, inflammatory diseases can also cause low bone mass and increased fracture risk. So I've told you a lot of things about things to worry about. So the next important portion is to address what can we do to boost bone mass and lower fracture risk. So shown here is kind of a simple picture showing what a healthy bone looks like, with thick cortical bone and lots of trabecular bone, which connects the cortical bone. And in osteoporosis, you have a loss of both types of bone. The cortical bone is thin, and there's less trabecular bone mass. And this decrease in bone mass increases our fracture risk. So how do we diagnose how do we measure bone mass? We use DEXA, which is a low radiation X-ray that's used to measure bone density. I imagine that many of you have had a screening DEXA scan. So when this X-ray is obtained, we measure the bone density. We obtain images of the spine and in the hip, and from those images, we calculate what the bone density is. And then from that calculated bone density, we calculate what's called a T-score, which compares what the measured bone density is to the rest of the population. So a T-score of 0 means that the bone density is the same as that of a healthy 25-year-old. And then the more negative that T-score gets, the lower that number becomes, the lower the bone mass is. So any T-score that's greater than -1 is considered to be normal. A T-score that's found in the range between -1 and -2.5 is considered to be osteopenia. And then a T-score less than -2.5 is considered to be in the osteoporosis range. And we know from a large number of epidemiologic studies that T-scores less than -2.5 correspond to significant increases in the risk of fractures. However, the majority of individuals who have bone density measured have bone density in the osteopenia range. It turns out that having osteopenic bone density doesn't mean that you're kind of off the hook. So what we want to do is to try to get more information about individuals whose bone density is in this osteopenic range to try to estimate fracture risk. So we have a number of tools that we use. Obviously, the clinical assessment by your primary doctor, gynecologist, endocrinologist is extremely important. But more recently, investigators have developed very powerful tools that can calculate fracture risk specifically for individuals with osteopenia. So FRAX is probably the most commonly used of those tools, and it takes into account your age, gender, demographic information, other clinical information, and then bone density. And from that is able to calculate what your 10-year risk of different kinds of osteoporotic fractures are. So hopefully, if your bone density is in the osteopenic range and you're found to be low risk based on the FRAX estimates, lifestyle modifications are really enough. And in terms of what those lifestyle modifications might be, we really think of three: calcium and vitamin D. And really the point of calcium and vitamin D is to prevent those parathyroid hormone, prevent those PTH levels from increasing. Because if they do, then the calcium is going to be coming out of bone. So in terms of where to get calcium from, dietary sources are far preferable to supplements. Some of the kind of the more common dietary sources of calcium are listed here: milk, cheese, and yogurt. And so if you kind of add up these numbers, you're pretty close to 1,000 milligrams a day, which is really where we want to be in terms of the amount of calcium that we're taking in each day. In terms of if you're unable to kind of get this much calcium through these common dietary sources, supplements are just fine. For the vast majority of people, calcium carbonate-based supplements are preferable. However, there are some medications that are used for acid reflux that make it necessary to take citrate-based calcium supplements. In addition to calcium, vitamin D kind of serves a similar role to help our gut absorb calcium. About 1,000 units a day are needed. And then finally, weight-bearing exercise, because really we want to avoid becoming an astronaut. And in terms of thinking about what kinds of weight-bearing exercise to consider, physical therapists or specialized exercise programs can be important, and it's particularly important to work on ways to avoid falls. A very commonly asked question that comes up all the time is, my bone density is low. What exercises are safe? What exercises are not safe? Luckily, most exercises are safe. Yoga is generally safe. Walking, tennis, kind of any sports that have a moderate amount of impacts are more than just safe. They're wonderful for our bones. However, there are some Pilates programs that I've learned about in recent years that are associated with kind of excessive spine flexion. And by that, I mean kind of pictures shown here, poses that would pose kind of extra stress on the vertebrae. And those have been linked to increased risk of vertebral fracture. In general, a Pilates pose like this would not be associated with that excess spine flexion. And there are some Pilates programs, such as the one that's listed here on the bottom of the screen, that have been designed specifically for thinking about women who have osteoporosis. And importantly, always you want to speak to your physician or physical therapist. And then finally, this is an area where surprisingly little is known. We know that, thinking about the vertebrae, that there's kind of, we talk about the bone density and the strength, and we talk about loads applied to the vertebrae. And somehow these two things are kind of contributing to lead to fracture. But exactly how these loads are applied to the vertebrae is remarkably unclear at this point. You could imagine that if the spine is curved in different ways, that could change the way loads are applied to the vertebrae. If muscle mass is excessive or absent, that could change loads applied to the vertebrae. And finally, different kinds of activity may change how how loads are applied to the vertebral column. So I'm fortunate to be involved in some work with Mary Buckstein, who's an engineering colleague at the Mass General Hospital, where we're trying to develop models to model not just the bones, but also the muscles, the vertebral discs, and to think about how exercise transmits different kinds of forces to the vertebral column. And the goal of this work is to predict relationships between activity, exercise, bone, muscle, and fracture risk. So I'd be happy to talk about these studies in the question and answer session or after the talks. Finally, what if either you're osteopenic and have high risk, or you have osteoporosis by bone density? Unfortunately, in this case, lifestyle interventions alone fail to lead to significant gains in bone density or reductions in fracture risk. So now, thinking about the osteoporosis medications that we have, we'll go back to our imbalance between bone formation by osteoblasts and bone resorption by osteoclasts. Anti-resorptive medications, which are really the first-line medications for osteoporosis, they work by blocking osteoclasts. Anabolic medications, which are much newer and not quite as developed class of medications, work by stimulating osteoblasts. So in terms of thinking about the osteoporosis medications that we have available right now, the anti-resorptives really are first line, and the names of those medications are listed here. Anabolic agents, such as teriparatide and abaloparatide, are promising new therapies. However, these medications require self-injection every day, which is kind of not a popular thing when I try to convince my patients to do this for a chronic asymptomatic condition. So really kind of a major unmet need in the field is the development of medications that build new bone that are pills that can be taken rather than injections every day. All the medications that I've listed here increase bone density, and they all reduce fracture risk. Because the bisphosphonate medications are really the first line anti-resorptive osteoporosis medications, I wanted to spend one slide talking about them and some kind of unfortunate reasons that they've found their way into the press recently. So bisphosphonate medications have been around for about 15 years. They've been shown to increase bone density, to lower fractures, but there are really two important but very rare side effects associated with bisphosphonates. The first is a condition called osteonecrosis of the jaw. This is really a dental infection that can't heal. To get this condition, you need to have bad teeth, and you need to be on very long-term high-dose bisphosphonate therapy. The incidence of this, very significant condition is very low, 1 in 10,000. The second rare but important bisphosphonate side effect is a condition called atypical fractures. And these are really stress fractures, not of the hip, but of the middle of the thigh bone. And again, these fractures are associated with the long-term use of high doses of bisphosphonates. And again, these fractures are very rare. 1 in about 5,000 for individuals treated for over 5 years. However, jaw necrosis and atypical fractures have made their way into the news and have been covered by the New York Times recently and have led to kind of dramatic undertreatment of osteoporosis. And the way I kind of think about this and discussing this problem with my patients is that while these conditions are real, jaw necrosis and atypical fractures, and they are associated with these medications, the risk of these complications is exceptionally low. And for high-risk individuals, the risk of hip fracture is quite high. So it's really a matter of balancing these risks and the benefits of reducing hip fractures in at-risk individuals. And generally, I favor the use of these medications in the vast majority of clinical situations. Finally, I wanted to talk about where I hope this field is going in the future. As I mentioned already, there's some major unmet needs for our patients with osteoporosis. We really need to come up with better ways to predict who is at high risk for low bone density, for poor bone quality, which I haven't talked about at all. We've really only talked about bone density, and for fractures. We need to think about we need to develop better strategies to prevent the development of osteoporosis. We need better information about how to use our existing therapies. We need improved knowledge about bone remodeling in order to try to identify new therapeutic targets. And finally, as I mentioned, we really do need new medications that build bone that are orally available to get around this problem with the current bone anabolic agents. So in the final slide, I wanted to mention some of the efforts going on in my group, which is located in the MGH endocrine unit. Toshi Sato, who's pictured here on the left, is working hard to try to understand how osteocytes respond to exercise. When that fluid flow moves over those projections, what happens in the cell to allow these potent responses to exercise? Fatima, who's pictured here in the middle, is trying to understand how osteocytes develop in the first place. It's really an amazing problem. You've got these cells that are buried deeply within bone. How do they get there, and what processes are responsible? And Maureen, who's pictured up here, has been working very hard to try to develop new drugs to build bone. In those efforts, we identified 2 genes called SIK2 and SIK3. When those genes are deleted, you can see a huge increase in bone mass compared to these normal mice where these 2 genes are present. So this is kind of a promising target for osteoporosis drug development. And so working with a number of investigators at Mass General, the Broad Institute, and the Dana-Farber Cancer Institute, we've been able to develop small molecule inhibitors of these kinases. And currently, this work is at a very early stage, but we have been able to see dramatic effects of these agents on osteoporosis in mice. So now the next steps are to test these agents in larger animals before we can think about moving into people. So hopefully this was kind of a whirlwind tour, but there was some educational value in terms of thinking about bone and how we think about osteoporosis. This is a living tissue. We have dramatic changes in bone mass over our lifetimes. There's a lot that we could do. There are lifestyle modifications and very effective and safe medications. And hopefully I've kind of given you a glimpse into our insights that we think the future is bright and there are going to be new therapies on the horizon. Thanks again for this invitation and for your attention. Oh, thanks.
Thank you so much for that. I wanted to remind everybody that all of these slides will be made available to everyone who attends. We're going to email them all out. I forgot about that myself. I was madly taking photos, and you will get them. Now, with that, can we take questions for Dr. Wine? Eileen?
Yes. Yes. That's an excellent question. So I kind of glossed over what is long-term use. Both of those two side effects, the jaw necrosis and the atypical fractures, are really only seen in patients who've been on these medications for more than 5 years. So for the first 5 years of therapy, those risks are not present. So hopefully within 5 years of therapy, we see adequate gains in bone density so that then a honeymoon or a drug holiday can be pursued. And so that, without a doubt, is the standard approach that we follow. And really the challenge is what happens if you treat for 5 years or more and the bone density is still low, or the risk of fractures is still low. And that's really where I think these bone anabolic agents come in, or considering other medications. So really, they're interesting medications because the balance of risks and benefit changes over time. So that's why I think a lot of thought is needed in terms of every year, is this really the right thing to do to continue with therapy?
Judy?
Was there any particular exercise that brought the astronauts back?
They're working on that, actually. It's a great question. So NASA is doing two things. They don't send that many astronauts to space anymore. They are trying to use Reclast, which is an osteoporosis medication, before the astronauts go to space to see if that prevents. And then in addition, what they're doing is using this kind of vibration device where the limbs are kind of, you put something here and something there, and you do that over and over again. And there seems to be a bit of a benefit. It's difficult. There are so few astronauts to study. But that's the idea, that if you can mimic loading, you might see benefit.
Yeah.
Absolutely. Yes, very important question. And obviously I focused on women because of the nature of this event. So men have similar rates of hip fractures as they age, but it really only ticks up at about age 75. So the recommendation for women is universal screening for osteoporosis at age 65. And for men, it's 75. But I do see a large number of men with osteoporosis as well. Thanks for that question.
Carrie? Oh, there's your specific case. Somebody. Oh, back there.
Excellent question. So as for skin, I'm not aware of any data. There's no data that supports the use of collagen, for oral collagen, really for any health benefits. The problem is collagen is a big protein. So you eat it, it goes into your stomach, and your stomach destroys it. So it's not getting into your bloodstream. The second question, I think, is a really important question. So bioidentical hormones or hormone replacement therapy, and I'm not aware of kind of a particular benefit of bioidentical hormones over hormone replacement therapy, but both are good for bone. Obviously, there are risks of hormone replacement therapy, breast cancer, heart disease. So, the balance needs to be considered. But, estrogen is certainly a good thing for bone, although we have other medications that don't have some of those risks.
I have two questions. One is, have you heard that carbonated drinks
Yep.
affect your
Yep.
bone? Because this is something we
Yep.
all drink.
Yep. Okay.
And the other one is, have you ever heard of Agical? Because some people can't tolerate calcium.
Yes.
Algae-based
Yes, absolutely. So the second question is easier. I've heard of Algacal, and it's a great calcium supplement. Calcium is calcium. So whether it comes from an algae-based or a plant-based or anything, that's fine. The question about seltzer has been coming up a lot lately. There was one study published in a high-profile journal that showed kind of a teeny tiny effect of carbonated beverages because of the pH of those beverages. It hasn't been replicated in other studies, and generally it kind of fits into a bill of effects of dietary changes that are pretty modest and unlikely to be something to really worry about, I would say. So I drink seltzer. It's great. Yep.
What's your opinion of medications like thyroid medications or cortisone shots on bones? I have two different doctors, and one's like, oh, give me cortisone shots and thyroid medicine saying it doesn't bother your bones at all. And then I have another doctor in Georgetown who's going nuts.
Yeah, good question. Absolutely. So thyroid medications, if you have an underactive thyroid gland, it's fine to replace your thyroid, with thyroid hormone replacement if you do it right. So the levels need to be followed, and overdoing it can cause bone loss without a doubt. So it is important to have those levels checked once or twice a year. Cortisone shots, probably there is some absorption of the cortisone from the joint into your bloodstream and can cause a little bit of bone loss, but it's not nearly as bad as if you were on prednisone or other kinds of steroids that are taken by mouth. So obviously, if you need a cortisone injection, you need a cortisone injection, but you want to try to minimize it.
I think there's one back there.
Yeah. So I wish we had better exams that could be clinically used. There's a lot of activity in the research side on developing better modalities to predict fracture risk beyond DEXA. For women or individuals with osteoporosis, the DEXA should be repeated every 2 years. For osteopenia, it can be spaced out a little bit more. Generally every 3 to 5 years is fine. It depends on how bad the osteopenia is.
Dr. Wine's going to be available. Well, I didn't tell me to cut this off, but it's cocktail time. So we're going to take a 15-minute break, and the doctors will be available for questions.
I'd like to introduce Dr. Caroline Mitchell. Thank you.
Thanks. So I'm sorry to interrupt cocktail hour to talk about bacteria, but I promise it's going to be informative and educational. And maybe not quite as fun as cocktails, but we'll get back to those later. So in the 1970s, the Boston Women's Health Book Collective published Our Bodies, Ourselves, with the then radical idea that if women understood more about their bodies, they would be able to have better health and be better advocates for their own health. And I would argue that the new frontier for the coming decade is understanding our microbiome, with the goal of improving our health through our microbes. I'm not going to talk about any therapeutics, really, so the disclosures are not quite as relevant. So in terms of the talk, we're going to talk about what the heck is the microbiome, A. Why do we think it's so important? Like, why should I know about this? And then we're going to answer some pointed questions that I'm going to use to illustrate how early we are in this field and really how much there is still to answer, which is great for my research career, but is very frustrating as a clinician. It is estimated that the weight of the microbes living in and on us is between 3 to 5 pounds. 3 to 5 pounds of bacteria in and on us. But it is not a 5 pounds that you want to lose. Those 5 pounds of bacteria perform innumerable things for your health and your body. They digest nutrients that we otherwise wouldn't be able to access from our food. They educate our immune system, what is self and what is foreign. They potentially help improve our brain function. I mean, our bacteria improve our brain. That's crazy. And we're starting to think that our bacteria should be considered almost another organ system that we should curate and care for in the same way that we care for our heart, our bones, or our skin. But so we've known about bacteria for a really long time, right? A really long time. So why now? What's all the fuss now? And the short answer is technology. 99% of the bacteria in the world cannot be cultured in the lab, which is crazy. And some of them, it's just that they take special care in feeding, not unlike some of our children. And so if you look for them and try and give them special food, they will grow. But in general, we just don't know they're there. And many of these are bacteria in the ocean or in the soil, but a lot of them live in and on us. And what has happened is that DNA sequencing technology, so the CSI of clinical medicine, where we can take the DNA from these bacteria and figure out who is there, that has become easier and cheaper. And so it has opened a world of this community in and on us that has changed how we think about health and being human. We are as much bacteria as we are human. The Human Microbiome Project was a project where they sampled with swabs multiple sites on the human body from 224 healthy individuals all across the United States. Now, these were mostly healthy medical students, so it may be a little bit of a skewed sample. But be that as it may, they sampled the bacteria in and on these people. The red numbers here are the number of different species found in those 224 people. And the green numbers are the number of different genes, or the number of different functions those bacteria can perform. And what you can see is that in the gut, they found a total of 4,000 different species of bacteria throughout those 224 people, with over 800,000 functions. In the gut, a diverse, robust community of bacteria is our friend. They digest nutrients, they educate our immune system. A diverse community is fabulous. I, however, am an OBGYN. I look at the vagina. In the vagina, they found only 300 species with only 10,000 functions. Now, lest we say this is because the female part of the body is less important, let me say, I think this means that the female part of the body is the most important. These bacteria are incredibly targeted. There is a very specific set of functions that these bacteria need to do, and evolution has created this pressure so that it is a certain type of bacteria doing something that facilitates reproduction, because evolution is all about reproduction. The fun vagina fact for tonight is that we are the only species that has this simple microbial community in the vagina. Not monkeys, not apes, not mice, not guinea pigs. No other species has this lactobacillus dominant community in the vagina. We are unique, which is great, but it makes it terribly challenging to be a researcher in this area because studying mice does not help me. So the healthy or a vaginal microbial community that is optimal for reproductive outcomes, for good reproductive outcomes, is dominated by one specific type of bacteria, the lactobacillus, that make lactic acid and keep the pH of the vagina low. It's very different than the gut. And it has this very narrow set of functions. But Dr. Mitchell, you say, you know what, all this microbiome stuff, how do you know it's not just a marker of something else? That people with diabetes have a certain type of microbiome because of the diabetes? Or people who have preterm birth have a certain type of microbiome in the vagina because of something that caused the preterm birth? How do you know it's the microbiome causing this stuff? Really? So here we are going to go to mice, and we're going to go to the gut because they can use mice for the gut, and it's a super cool study. They took twins, one of whom was thin and one of whom was obese. They took their gut bacteria, yes, from their poop, and they gave it to genetically identical mice. The mice that got the microbes from the obese twin became obese mice. But the genius of this study is what happened next. And to get the part that happens next, you have to know that mice, when put in the same cage, eat each other's poop. If you put them in the same cage, the fat mice became slim again because they got whatever the bacteria was from the skinny mice that facilitated skinniness. And I am quite sure there is a company in Kendall Square making a skinny poop pill right now that will be coming somewhere near you. And I'm sure you may have heard about fecal transplant. So for people who have this really terrible infection of the intestines called Clostridium difficile, getting a transplant of healthy bacteria can be curative in a really remarkable and dramatic way. And there's a story about a woman it's a case report of a woman who was very slim, got C. diff, got a fecal transplant, and began gaining weight. Again, likely because the microbiome that she got optimally delivered calories to her body. And so this, again, in obesity, I think this is a very intuitive place where you're like, okay, I believe that microbiome causes this. But there are plenty of studies in mice showing that the microbiome do appear to have a real causative role in many of the outcomes that we're looking at. Because if you change the microbiome, you change the outcomes. So you won't be surprised to hear me say that microbiota, or the microbiome, also impacts reproductive health. So women who do not have this lactobacillus dominant microbiome are at increased risk for preterm birth, miscarriage, persistence of HPV in your cervix, and increased risk for HIV acquisition. Now, many of these things have multiple other things that also alter the risk. It's not like it's only the microbiome, but the microbiome plays a key role. And I'm going to use data from a collaborator at the MGH about HIV acquisition to really illustrate this causative role of the microbiome here. So over half of the women in the world living with half of the people living with HIV in the world are women. And young women are acquiring HIV at significantly higher rates than young men. And nowhere is this more clear than in sub-Saharan Africa. My collaborator, Doug Kwan, who works with Bruce Walker at the Reagan Institute, is part of a cohort of young South African women in an area called KwaZulu-Natal, where the annual incidence of HIV is 6 to 8%, which means that when you're 12 to 14, the prevalence of HIV is close to 0, and by the time women are my age or older, it's 50 to 60%. It's dramatic. And so this is an area where interventions to decrease HIV acquisition could make a tremendous impact. And one thing to know about the vaginal microbiome is we know in the United States, African American women are less likely to have the lactobacillus that we think of as being optimal. So is that also true in Africa? And the answer is yes. So in this type of graph, it's called a heat map. Each column is a person, each row is a bacteria. Blue means that bacteria is not detected, and red means it's like 100% of the community. So over here, you can see this group of women has not a lot of blue and a lot of kind of yellow, which means they have a lot of different bacteria, a little bit of everything. So this is a diverse community, which would be great for the gut, not so good for the vagina. Here we have a group of women with a lot of blue and just this little band of red. So this Lactobacillus crispatus is almost 100% of the bacteria that we find in the vagina. And then the people in the other two groups that are sort of delineated there are a mix. And I'll say this Lactobacillus crispatus is what is most common in white American women. So do these two groups of women, the women with the lactobacillus and the women with the diverse community, do they have different risks of acquiring HIV? And you're not going to be surprised by the answer, but it's a 4-fold increased risk of acquiring HIV in the women with that very diverse community. So the purple line here. The yellow line across the bottom is Lactobacillus crispatus. None of the women with this Lactobacillus crispatus acquired HIV in this study. So why the difference? Great question. We have no idea. And there are many things it could be. It could be genetics, it could be environment, there are all kinds of things. All of those are pure speculation at this point. It is very challenging to do these studies, but clearly an area where we need to learn more. So can we change it? Right? If we know that lactobacillus is good, let's put them there. Right? That seems logical, clearly. So probiotics. So to feel like probiotics are going to work, you need to know that if I take this pill, it's going to end up in my vagina. Most of the studies don't look because they're funded by the companies. They don't actually care. They just want you to buy their product, so they measure something else. If you look, so this is one study that looked at this product, and measured, you had to have only one of these, got you a positive. You didn't have to have all of them, you just have to have at least one. And the maximum percent colonization, only 60% of women taking this daily for 60 days, could we find this in the vagina. And if you stopped taking it, which is that dotted line, the colonization goes away. So it's a great model for the company, where you have to take their product every day forever, but not a great model if you're the consumer. In this other study with a different product, here the graph is showing the increase in quantity of these different microbes. And you can see there's one line that's far and above all of them, and that's that Lactobacillus rhamnosus. Increased in quantity, and here the dotted line also is when people stopped taking the probiotic, and the quantity continued to increase. So this one, all right, seems biologically plausible. So if most studies aren't looking at colonization, what are they looking at? So they're mostly looking at bacterial vaginosis, which is a condition where the vaginal bacterial community shifts from being lactobacillus dominated to being that diverse community. And we can treat the diverse community with antibiotics, make the bad bacteria go away, but the recurrence is as high as 50% in 6 months. And so part of that is because the good bacteria don't come back. So if we could give the good bacteria back, maybe we could prevent the recurrence. This is a summary of all the studies I could find that were randomized. They had a placebo arm, so reasonable quality, although I'm going to say later on the quality of any of these is really not would not be acceptable to the FDA for approving this in the United States. Green bars here are the cure rate of the probiotic. Blue bars are the cure rate of the placebo. You can see for most of these, the blue and green is kind of the same. These three are where the green bar is higher than the blue bar. They all are orally delivered, and they all included this Lactobacillus rhamnosus that we saw on the prior slide, seemed to colonize well and seemed to keep increasing even after you stopped taking it. So what I tell my patients is, A, I'm not sure $50 is well spent on probiotics at all. But if you feel like you want to take a probiotic for your vagina, pick one with this guy in it. And there's a Lactobacillus rhamnosus GG that's very good for the gut, but does nothing for the vagina. It has to be this Lactobacillus rhamnosus GR. But again, I'm really not sure it's a $50 well spent, because the quality of these studies is poor, and no one has really done the underlying fundamental science. So there is one company that is trying to do some science, and I'll say most of those studies on the prior slide all include gut lactobacillus or dairy lactobacillus, because those are super common. People have them in yogurt. They sort of know about them, but they're not the kind of lactobacillus we find in the vagina. So Lactobacillus crispatus is a very common vaginal lactobacillus. It's the one that in the South African women seem to protect against HIV. And so, well, yeah, that's the one we want, right? So this small company in California has been working on this for over a decade. They have a phase 1 and phase 2 study published, which is safety and sort of how well tolerated it is. The phase 3 study to find out if it works is ongoing right now, and we should have data about that in the next year or two. When people use it daily for 5 days after being treated for bacterial vaginosis and then weekly for 2 weeks, the colonization still is not so fabulous. It's 50 to 44%. It's less likely to colonize if you already have lactobacillus. And if you're sexually active in that time, you're also less likely to colonize. So this is probably not the perfect product, but it may have some efficacy, and we're actually considering a trial in the South African women to see if we can, even a small benefit there would be tremendous in terms of HIV risk. But lest we forget that Mother Nature is complicated, I'm going to give a small cautionary tale about interfering where you don't understand what you're doing. So Lactin V, this product, has been used in a trial to look at recurrent urinary tract infection, which is a big problem for a lot of women. And so if we could prevent that, that would be great. So they randomized women to this Lactin V product or placebo and followed them for 2 months. And they used it really daily for 5 days and then were followed for 2 months to see if they had a recurrent UTI. So if you were in the placebo arm, the green bar here is people who luckily even though they were on placebo, got a ton of lactobacillus in their vagina during those 2 months. And blue is the people who still didn't have a lot of lactobacillus by the end of the study. And you can see their risk, that height of the bar, their risk for a recurrent UTI in this time is the same. If you got lactin V and you colonized, so you're the green bar, you were protected. If you did not colonize, you had a tremendously increased risk for recurrent UTI compared to your cohort that did colonize. This is 7 women, so it could be a fluke of the data. It could be that here we're uncovering a very genetically unlucky group of people who were never going to colonize anyway. But why didn't we see that in the placebo group either? And I think this speaks to maybe by putting in this exogenous lactobacillus, we disrupted a balance. We did something that put these women at risk if they didn't colonize. And you never know if you're going to be the one who colonized or didn't. At least we don't know so far. So proceed with caution is my advice about probiotics. And the sad truth about probiotics for the vagina, and I'm not talking about the gut because I am not a gastroenterologist, and it's a very big field and a very big literature, and so we're really just speaking about probiotics for the vagina. Almost none of the probiotics include species or strains that are specific to the vagina. Most available studies are tremendously poor quality. And probiotics are not regulated by the FDA, and at least one study, when they tested to find out is it what's in it actually what it says on the label? No. Some of the time, no, not at all, not quantity and not even species sometimes. And then let me just also talk about yeast, which is that in the lab, lactobacillus, especially dairy lactobacillus, kill yeast. But when I diagnose people with yeast in the clinic, 90 to 99% of the time, lactobacillus are there right alongside of the yeast. So eat yogurt to help your bones. The yogurt is doing nothing for your vagina. So the other part of my job is that I'm an obstetrician. And I think a lot of you have heard, C-sections are doing terrible things to our children. And people feel terrible if they have to have a C-section. So C-sections are life-saving. C-sections are an intervention that has changed motherhood and the possibility of motherhood for many women, and they're not going away. So, but are they a problem? And the reason, from a microbiome standpoint, some people are asking this, is because the microbiome of babies, so the gut stool microbiome of babies born via C-section is dramatically different than that of babies born vaginally. So this type of plot shows time on the x-axis, the colors are the different families of bacteria, and the width tells you the proportion of the community that is that type of bacteria. The top row is vaginally delivered babies, and the bottom row is C-section babies. And I think you can see the bottom row has no blue for the first year of life. You're like, okay, Dr. Mitchell, I see this. This is easy. We just give the babies back the blue bacteria, which we've shown is maybe harder than it looks. And B, they get the blue bacteria anyway, so does it really matter? And this is one of the things that my professional organization, ACOG, has said, the babies get the bacteria anyway, so let's not do any crazy interventions. I agree with the not do any crazy interventions, but I'm going to tell you that those bacteria in the first year, and in fact the first months of life, are incredibly important. And here we're going to go back to mice. So germ-free mice are the boy in the bubble of mouse research. So they're mice raised without any bacteria at all, which admittedly makes them wacky, because we know now that microbes are part of being healthy. But so these are boy in the bubble mice. And then researchers said, so what if we give the mice back bacteria on day 1 of life or at 5 weeks of life when they're teenagers? And then at 9 weeks of life, we give them a challenge that would cause colitis, so a bad bacterial infection like Salmonella or E. coli, one of the things that cause terrible inflammation of the colon. Doesn't matter when you get the bacteria back. And we know that mice without any bacteria at all have terrible colitis, that having bacteria in the gut is protective. So what if you give it back early versus later? And I'll tell you that 5-week-old mice, they called them aged mice in this study. So here, the graph on the left is a survival curve. The lower you are in the curve, the more likely you are to die. So those 2 lines that go down, those are mice that died. And those are the mice that didn't have any bacteria and the mice that got bacteria at 5 weeks. The mice that survived are the mice that had bacteria from the very beginning, or the mice that got bacteria on day 1 of life. And the bars on the right are the score of inflammation in the colon. So again, there's much more inflammation and almost as if you had no bacteria at all if you got those microbes late. And this is because the bacteria in our gut educate our immune system about what to respond to. They tell us, should we be inflammatory or not? Should we be tolerant or not? And so having those bacteria early on is incredibly important. There are some data showing that babies born via C-section have increased rates of obesity, increased risk for atopic dermatitis, eczema, asthma. And again, there are a lot of things that go into that, but possibly the microbiome plays a role. And so if we could figure out how our delivery mode, like what I'm doing, determines a baby's gut microbiome, then it would be great if we could prevent this change. You may have seen this in the New York Times or heard it on NPR. This very elegant seeming intervention that babies born via C-section, let's just pretend they came out the vagina and smear vaginal fluid all over them. Simple, right? Low tech, super easy. This is a study I love to hate. And you would think, pages of the New York Times, NPR, published in Nature Medicine, which is a relatively high-profile journal. I'm going to show you the numbers of how many babies this was. 4 babies got the intervention. 4. And it was not even randomized. They cherry-picked the babies with moms who had the healthiest vaginal bacterial community. And then they compared them to 7 babies born via C-section and 7 babies born vaginally, and the other C-section babies didn't have any vaginal fluid smearing. And then, so I've told you that it's the gut, the intestinal microbes that really determine our immune profile, that educate our immune system. So what these researchers measured is swabs of the skin that they had just smeared with mom's vaginal fluid. So I'm not going to show you the results because they found a difference. Of course they found a difference. And I'm giving them a little too little credit because they did follow the babies over a month. But it's the wrong outcome. We want to know, where's the poop, right? And they haven't published that yet. And I think it's because it's not different. But, so this is a study done in Canada where they did measure the poop. This is at 3 months of life, so it's a little bit later on. Here, it's a collection of all the babies in that tall column. And again, the color is the proportion as the total part of the community, but this is all the babies sort of lumped into one column. The orange color here is that blue bacteria that was missing in the C-section babies before. And I think you can see the vaginally delivered babies are on the left, and the C-section babies are on the right. And you can see the orange color is much smaller in the C-section babies. But you say, Dr. Mitchell, I know this one, I got it. Everyone who has a C-section gets antibiotics. This is the problem. So it turns out a lot of people who have a vaginal delivery also get antibiotics to prevent group B strep. Those babies are kind of in the middle, but they look a little bit more like the vaginally delivered babies than the C-section babies. Then you say, but all right, I have another group for you. What about the people who are in labor for a gajillion hours and then get a C-section anyway? I'm pretty sure those babies got a lot of vaginal exposure. They look like C-sections before labor. And this, we all want simplicity. We want the things that seem elegant and natural and easy. But nature is not simple. Nature is incredibly complex and beautiful and incredible and really hard to understand. And I'll say here that what I didn't talk about, breastfeeding, makes a huge difference in the microbiome. And really, if you want to do something good for your baby, don't smear the baby with vaginal fluid. Breastfeed the baby. That is going to be the money intervention right there. So in summary, the microbiome is super important, and it likely defines many aspects of our health. But microbiome interventions are not straightforward, and we are just barely beginning to understand what's going on. A lot of the new technology that we have just tells us who's there. It doesn't tell us what they do. right? And just knowing who's there may be only a small fraction of the story. Specifically, probiotics for the vagina have very limited scientific basis, is probably a waste of your money. And seeding of babies after C-section has even less scientific report. Please don't do that. I will, as a shameless plug for my own work, say that with a collaborator from the Broad Institute, we enrolled 190 women at Mass General, delivering either via vaginal delivery, C-section, or C-section after labor, are in the process of analyzing those data to try and get a sense for when are the bacteria transferred, what is transferred, can we start to shed some light about how this is all happening and when, and hopefully those results will be published by the end of this year. So many thanks. I didn't talk at all about my lab research nor about my clinical practice in the vaginitis clinic, but I love to talk about the microbiome. I'm happy to answer any questions, and really thanks for your attention.
That was amazing. Thank you. So thought-provoking. Are there any questions for Dr. Mitchell? I see one over there.
What's the status of the microbiome of a baby that's born completely exposed to antibiotics?
So a baby that's born in the amniotic sac, no one has looked. It is a rare enough occurrence that no one has looked at. Does it matter if the amniotic sac is broken or not? I think probably whether you come out the vagina or via C-section matters more.
Any other questions? So one over there. Oh, sorry.
My question is, I know you said you're an obstetrician, but what about, has there been data that's saying probiotics, you're saying it's not going to do much for the vagina, but there is data that says probiotics for the gut has been studied, and that's possible.
So probiotics for the gut. I think it's probably as fraught a question there, and which one is the right one. But I think it is more standard intervention. And I'll say one of my favorite studies, there are probably pediatricians here, so I may get in trouble, but there's this really lovely study of babies born slightly preterm who are at high risk for respiratory syncytial virus or RSV infection. And this is in one of the Scandinavian countries where probiotics are much more common. And they randomized kids to get probiotics versus placebo. And the kids who got probiotics for the gut, so oral probiotics, had lower rates of RSV infection. So gut probiotics have a role in 6 million different things, but it is still a very new area. And so I really hesitate to comment because it's not my expertise, and I think there is nuance anywhere.
Can we go back to the study about the African women that
Yeah.
had AIDS in comparison to other women? Because I'll be thinking about this tonight and wish I had asked. Was everyone equally exposed to HIV?
So the question is, in that study of the young South African women, are they all equally exposed? So this was not a partner study. So the partners of these young women were not evaluated, tested. So we don't know how many women had a positive partner. But because the chance of getting HIV in this community is so high, and these women are in the age group.
Because men have HIV that they're
Right. So there's this the research group in KwaZulu-Natal that studies this has done this really tremendous sort of analysis of the cycle of HIV transmission, which is that often young women are with an older male partner who then infects them. But where did that older male partner get that? It's from his wife, who is 40 and had HIV from when she was younger. And so it's this cycle of transmission that we have to break somehow. And one thought is that women in Africa may be more susceptible because of the vaginal microbiome. And we don't understand why there is a difference in the lactobacillus prevalence of the vaginal microbiome in Africa or in African American women. But it clearly puts people at a higher risk for both infectious complications, but also preterm birth. And we know that certainly in the US, preterm birth is much higher in the African American community. And it may have to do in part with the vaginal microbiome.
You showed a chart with the C-section babies, and at birth, they didn't have any of the blue but at 1 year they did. So
Right.
what happened?
I wish I knew. So what happened? Why did they get the blue bacteria? It may be that it was there all along in really small quantity and something allowed it to grow. It may be, we're not always the cleanest people, especially when we're one. And we know that babies with siblings or pets in the house have differences in the microbial community of their stool. So we get our microbiome from all kinds of environmental and personal influences. So we have no idea. No one has looked at when those babies get the Bacteroides back, where is it from? Again, it's like the dawn of this research. There's so much to know.
Well, it was interesting because it looked like it went from like 0 to 60.
Yeah. And that graph was very much a schematic to illustrate the point. The specifics are different for each person, but yeah.
Thank you so much. The doctors will all be around after for more questions. And before I turn it over to Dr. Margot Hartman and Melanie Sablehouse to close, I'd like to personally thank everyone for coming and also remind you this year you get a little takeaway. So make sure to get your special Women in Wellness water bottle on the way out.
Thank you.
Melanie.
I want to thank their doctors coming to visit us. We are so fortunate that we are partners with MGH. We really are. So we want to thank you very much for taking your time to educate us. Ladies, you make 80% of all healthcare decisions in your family. Besides being the economic powerhouse of the 21st century, you are the chief medical officers of your home. You make the decisions for yourself, your husband, your kids, and when you get to be my age, your parents. And as you had said to me, your mother calls you the general contractor, and we are. So I guess we're general contractors across the board as far as women. We learned a lot, which is fantastic. The subjects that we chose were because you gave us as input what you wanted to learn. So what we're going to ask you right now, did we empower you? Do you have new information that you can make better decisions? We want to thank our doctors. We're going to be asking you again, what would you like to learn? What do you need to know more about? Any ideas right now for next year? Because this is a fabulous program. What else would you like to learn? What subjects? Digestion, fantastic. Anybody else? Eyes. This is interesting. Anyone else? Tick-borne illnesses. Anyone interested in heart and AFib? I am, absolutely. I want you to know hospitals across the country are doing what we're doing right here on our island. And we're gathering women, educating them, empowering them so they can make the best healthcare decisions. I'm going to close right now by bringing Margot up, but I want to tell you something very exciting, and that is that our hospital, which is about to open this year, this has been this is a record-breaking year for us. We have raised $1,011,000 over how much? $111 million for this hospital. And thank you. And it's because of you. Because in 3 seasons, we were able to raise that money to build this debt-free hospital because of you. So I want to thank you very much for all of that. Margot's going to do a close, and she's going to talk to you about the new hospital and talk to you about the fabulous 12 doctors that we have, which are our resources. Thank you, Margot.
Thank you. So this extraordinary project is coming to fruition. We will be treating patients in our new hospital by the end of this calendar year, and that's an amazing thing to be able to say. But as extraordinary as it is to be able to give people the best possible experience, whether staff or patients, and a beautiful hospital that enables people to bring their A game, it is the people who work inside it who deliver the care and who contribute to the quality of what we have and what we need. So let us know what we need to be for you. And understand that we're often more hospital than many people realize we are. And please take the time to learn about us. And a great place to start is actually on our website. And recognize that we have extraordinary partners in MGH. And we are more and more connected with MGH and our remarkable colleagues. And that serves you and it serves all of us. So thank you for knowing that. Thank you for being here and for caring about your hospital. Thank you. Oh, yeah. And also to all of the staff who contributed to this remarkable event. Courtney and all of her team, you made a difference. Again, thank you.